We're going to talk through some sort of practical tips about what you should do when you get that letter, that email, whatever the communication is from the payer. Usually what happens is you get a request for a number of charts, a bunch of patients on a bunch of dates of service, or every once in a while, if there's a single patient that they want to see over a course of treatment. But one way or another, the way these audits happen is through record requests, and I'm sure everybody watching is familiar with those. So let's go ahead and get the next slide. It's really important to have a good strategy for responding to the record requests, because what you do in the first response really shapes everything else that's going to happen over the course of the audit and any potential appeals. So we want to give you some tips about responding to that audit. Number one, I cannot stress this enough, all caps for a reason, don't alter your existing records. And, you know, it's one of those things where we can all sort of chuckle about it. Oh, nobody would ever do that, whatever. I have the t-shirt for the case that should have been a routine overpayment case. Yeah, we were going to be able to argue some, we were not going to be able to argue others. There would be a small amount of money paid, fine. Turns into a fraud case, because once the auditors see, detect that there has been editing of the record after the fact in a non-contemporaneous way, and sometimes years after the fact, they all of a sudden think, okay, then I can't trust anything that's been sent in. And they're going to look much more skeptically at all of the other records that are sent in, and they're going to consider whether it's appropriate to bring a fraud action, because how can you possibly know in 2021 what you did in 2019? So I can't emphasize this enough. If you are reviewing a record before submitting it and you realize that it's incomplete, it's fine to add a note that's dated today that gives the supplemental information, or as in my final bullet point on this slide, add an explanatory letter about what your process is for dealing with a particular. I actually had a dermatology audit once where we used the explanatory letter to walk through what the physical exam looked like for each time, and we
very
had
common, honestly. I mean, yeah, most people. I mean, it's very common to add those letters explaining it if the record is somehow unclear. As long as you're
that's exactly right.
You're doing it today.
Right, that's exactly right. And you need to date. You need to date your letter. You need to date whatever supplemental note you add. What you must not do, and in the world of electronic medical records, it's really easy to detect if somebody's messing around with a prior record. So don't do that. That makes our job much more difficult, and we have to have much harder conversations with our clients once we get called in.
Yeah.
Okay.
I mean, we had a case recently where we dug a guy up from 6 years before. He moved to Maine and was retired from practice, even though he was only in his mid 40s. But we dug him up. We said, "Hey, do you remember these? Remember this?" And he's like, "Actually, I kind of do." And you know, it took me a minute, but I refamiliarized myself. And you know, we went to an ALJ hearing with him, and he did great. He's like, "Yeah, I spent some time reviewing these records. I actually do remember this patient. Remember I talked to her about her dog or whatever it was, and you know, he was able to do it and was very credible. But you know, it was important there that you know, nobody tried to actually alter the record. But he said, yeah, look, he screwed up. He failed to document that thing back in the day, but he's here now, and he can tell you that was present, and he remembers it, and here's how he remembers it.
Yep.
And it was still quite powerful.
That's right. And it becomes everything we are doing here. Every one of the next few bullet points that we're dealing with really goes to your credibility as a practice in responding to these audits and making the persuasive case that you earned the money that was paid, or that you have earned money that's about to be paid in the prepaid context. Okay, timeliness matters. Timeliness matters. Timeliness matters. Here is the thing about that. When you send stuff in late, or if you fail to respond at all, the auditor is going to assume that there is no record, and you put yourself, back to our credibility problem, you put yourself in the situation of, one, signaling to the auditor that you don't actually care about this audit, it's not important to you. And also, you are putting the auditor on notice that maybe anything you send in the future is something you just trumped up, because if you had the existing records, you would have sent them. So timeliness matters. Here is the thing that you need to do if you get a request for records and it says we need these records in 30 days. There's always a phone number, an email address, some way to contact the person that you sent the letter. And many times, if you get there early enough in the process and reach out to them, you can say, I need an extra few days. Most of the time, they'll let you do it. They'll give you the extra few days. You want to confirm that by email in writing. But
On commercial. Now, Medicare, Medicaid is not usually so sympathetic, but yeah.
Well, they have regulatory deadlines. That's true. But I also wouldn't hesitate to try, even with Medicare, because the thing that you are signaling then is, I've got it, I'm on it, I'm working on it, I'm taking it seriously, I need a little help. There's nothing wrong with any of those, even if the answer is, by regulation, I'm not allowed to give you extra time. So timeliness matters. Education of your entire revenue cycle staff is key. What we mean here is that you have to make sure that everybody who might receive an audit notice and might participate in creating the records understands how important it is. This is not a letter that can go to the bottom of anybody's stack. It really needs to be a high priority from the moment it gets in. So you need your team to be trained to recognize them and to understand how they're going to respond to them. And that's true for your administrative staff. That's true for your medical staff. I know it's a pain in the neck when somebody from records or from the billing department comes and wants help from a physician on preparing a record. Everybody needs to understand how important these things are, and that a prompt complete response is essential. The next one is take responsibility for reviewing the records. So this gets back to a point that Ross made a little earlier in the presentation. Don't let your most junior administrative staff person be responsible for collecting the records, uploading them onto the website and hitting send. Make sure that a clinician, and preferably the clinician actually involved, is reviewing what gets sent. I can't tell you the number of times I've come in an appeal situation, and not only have I looked at the record and said, well, weren't there any x-rays done? Weren't there any lab tests done? How come those results didn't get included? And not only has it been me, and I'm not even a clinical person, I have worked with the physician who's responsible and whose money we're talking about, and they will say, well, this record is incomplete when they're looking at it after it's been submitted. There was a lab test and I reviewed an x-ray or whatever it is. Make sure you do that on the front end. Make sure a clinician is looking at the record on the front end to ensure that it's complete and tells the whole story. It is much easier to make a case, and I'll just give an example in evaluation and management coding. Most of the time when you bill a level 4 or a level 5 E&M code, those coding decisions turn on medical complexity or complexity of medical decision making. And if you're not going to show the results of diagnostic tests and that the physician took those into account, it's much harder to make the case just from diagnosis that there was complexity of medical decision making. So, and then we've already We've already touched on adding an explanatory letter if the record is not complete, or as in my dermatologist example, if there is a process that you go through that maybe is assumed by the record, but would benefit a reviewer to understand through explaining, that's a perfect time to put an explanatory letter in with the record package that you submit. Can we have the next slide, please? Okay, keep good records of what you actually sent in response. Here is the thing about that. Ross and I have both been in the audit situation where somebody responded to an audit record request, got a demand letter back for 6 figures, and now wants to engage our law firm to do an appeal. Our first question is always going to be, okay, please send me a copy of what you sent in. And a lot of times the response to that is, well, I'll have to get someone to go back and pull those patient records again. And that's when Ross and I start tearing our hair out, because what we want to see when we ask you that question, we want to know exactly what it was that the auditor received so we can evaluate. Was the complete record sent? Is there any information missing? Was too much sent in? We want to know what actually went over so that we can start creating the argument based on what was sent and whether we need to supplement it. And this is really important when you're uploading your response. If there is a way to make a PDF file or put a folder on your computer or a thumb drive or whatever works for you, that is an accurate record of what was actually sent. That is so helpful as we work through the audit process. Next bullet. Send everything right on the first opportunity. This actually ties in, a lot of these points are interrelated. This ties into have a clinician review the record, make sure that it provides the full story. I have had auditors say to me, we really put most of our emphasis on the records that were sent in response to the first request. And we generally assume, and this is not fair, of course, but we generally assume that anything that gets sent in after that is something that they created. And it's going to have a lot less credibility. Fine, that's jaded and cynical and whatever, but it just makes the point. Make sure that all the x-rays are in, that if there are hospital progress notes that need to be included, that those get included, lab tests. Make sure that everything is in, make sure that everything is readable to the extent that it can be, that they are good digital copies of what you are sending in so that they're useful. And where there is a need for a supplemental note or an explanatory letter, don't forget to send it in right away. It just doesn't have the same force when you're sending it in an appeal context. And then what you end up with is trying to convince an administrative law judge at a higher level using actual live witnesses. It's just much harder, much more complicated process. Strong audit leadership and engage with the payers as soon as you can. So what we really mean here is this needs to be a priority. And anytime you have an opportunity to connect with the auditor who has done the request, you should do it. You should be convincing them that you are taking it seriously. If you have questions about what they're asking for, you should ask the questions. You should let them know that you are deeply involved in getting them a response in a prompt fashion. The results just work out much better than if you are trying to backfill when you have sent stuff in late or when you didn't understand what they were asking for. Those are problems that are very difficult to overcome through the appeal process. Okay. Now I have my less logistical and more general comments. There's an associate I used to work with who says he heard me say this sentence more times than he could count, and he kind of got tired of hearing it. But the first thing I will say to a physician practice, and particularly to the physician who calls me to deal with an audit, the first thing I will say is, this is not about the quality of your care. It is only about whether you kept good records. This is a bookkeeping exercise. You could have had the absolute best quality of care and great patient results. And if your records are terrible, they're going to ask for a lot of money back, even though you otherwise did everything right. And that isn't an indictment of how you treated your patient. It's an indictment of how well you kept the records of treating your patient. So don't take it personally. Audit is what it sounds like. It's just like an accounting audit. It's just like when your books are being looked at. We almost don't care about the substance. What we care about is, was a reliable record kept? Remember that nobody is perfect. And here's what I mean by this. The likelihood is when you get an audit request, you're going to be writing a check. Our job is to try to make that check as small as possible. But the reality is, when people do audits, when payers do audits, they are going to find things because nobody's perfect and all of the records aren't perfect and they never will be. Give yourself some grace around that and understand that a situation where you have a relatively small repayment is a win. We're almost never, I have one time gotten a complete vindication of the physician's payment, and we had a zero repayment to make. That one was unbelievably unusual and was a situation where the physician had just absolutely pristine records, on top of which we put the explanatory letter about what her process was. That almost never happens. You're almost all the time you're going to be writing a check. And I think in this right now is the time to say, we as lawyers have a kind of priority about any kind of audit or government investigation or any situation where you are interacting with, particularly with government payers. And that is this. The most absolutely important thing to do is to make sure there are no criminal charges. The second most important thing to do is make sure that nobody gets excluded from Medicare. The next most important thing is to convince the payers that no fraud is going on, that any overpayments are just simple overpayments. And if we get to that point where we're just talking about simple overpayments and we're only talking about the money, we already have won in a way. And so we do fight to get that dollar amount reduced. But at the end of the day, if you are paying just an overpayment back, then in a lot of ways, that's a big win. And finally, on this slide, it's really important not to waste your time on unsupported arguments. If you have a terrible record and you don't have a good memory of what went on with the patient, that's a claim you should just concede, because the only thing you do by arguing about every single claim along the lines of, but I always do it right, and I do that with every patient, and I don't actually remember seeing Sean Timmons in my office, but I'm sure I treated him the same way that I treat everybody else. All you're doing is calling your own credibility into question. Most of the time when I've had successful results, particularly in government investigations, but even in audits, it's because I was willing to go in the appeal and say, we get it, we did these ones wrong. We're willing to live with it. Let's talk about these other ones where there are some questions involved, because then the auditors or the administrative law judge or the U.S. attorneys understand that they are dealing with someone rational.
I'll add too, this isn't the time for personal or political commentary, on big companies or what a good doctor you are or things like that. The only caveat I will give you is if you are somebody who is really unique in your practice area, or you're in a really rural area, sometimes we will mention that. But it doesn't, that doesn't get you very far. It might give you a little bit of sympathy, but not very far. You know, they read right past that at best, and at worst, as Sean's saying, it turns them off when it affects your credibility. So I would recommend getting straight to the claims, the documentation, and kind of leave your personal indignation aside whenever possible.
Absolutely agree.
What else do we have, Sean?
Well, let's go on to the next slide. Here is we're about to enter into the part of this that is a little bit unspoken, and that is get help. When you're doing these audits and appeals, get help from an experienced lawyer who has done them. If you have a lot of documentation issues, particularly E&M coding audits, where you have multiple factors going on, get help from a consultant to objectively evaluate what your records look like and understand what you're getting into. And the reason I say that is because, and this is really Ross's point to make, but state law and your payer contract are your friend. Mm-hmm. But I don't know how many of you have spent a lot of time really digging in and reading hard your payer contracts. It is absolutely the cure for insomnia, and you need somebody who understands what the contract law is in your state to understand how to use that to your advantage.
Right, or state law. You know, for example, Texas and some other states have prompt pay laws that prohibit shenanigans like, you know, auditing before they make payment and things like that. So, you know, you need to be talking to someone who understands that for you as well. What about the document production strategy, Sean?
So this is making sure that you're being sensible about what you send in, right? It's really important to send in a complete record. So when you get a request for a particular CPT code, a date of service, and a patient, make sure you send in all the information about that patient encounter. And that sometimes will include information. If it's a follow-up visit, for example, that would necessarily include some information from prior visits. But my absurd example on sending in documentation that's not going to help you and actually could make the auditor upset or make them gloss over stuff that is actually important is if you got a patient for 15 years and you see them 3 times a year over the course of those 15 years, and the auditor is asking about one particular encounter, and you send the entire 15-year record, you are shooting yourself in the foot. You are asking them to just flip pages and gloss over the important stuff. So make sure.
Find something that they didn't audit, but now they have a problem with.
Well, and that's true too. That's exactly right. And so this gets back to the points that we've made earlier about making sure that you have a physician or somebody who really understands what records need to look like, a trained coder, evaluating what pieces of paper, I'm so old school, that's how long I've been practicing, what documentation needs to be sent in.
Yeah, and that's a good point there on the vendors. I mean, so many practices these days are using vendors for their billing, and then they just trust them to send it out the door. I mean, that vendor usually has very little incentive to get it right or wrong. In fact, I mean, talk about using the lowest paid person in the company to respond. They're definitely going to do that because taking time away from their other jobs is not something that's a high priority for them. So they're definitely going to say, all right, well, Timmons has got another audit, just throw the documents on the portal and let's be done. Like, so even if you have a vendor, and there's nothing wrong with that, but I suggest you engage your vendor and then exactly what they're sending out the door on your behalf. Because I've seen that, especially a lot more in recent years, where they ended up in weird audit situations, partially because the vendor wasn't paying attention, or the vendor just didn't care enough to really respond to it properly. And in fact, one audit we had last year, we figured out that part of the problem was the vendor itself. Blue Cross had become aware of this particular vendor, did not like the way they played on certain things, and was therefore auditing payers that appeared to be using that vendor, which was kind of crazy. So that providers that tended to use that vendor. So we had several providers that were like, wait, what did I do? Like, well, you didn't technically do anything. They just don't like your vendor. And so now you're getting audited. But you know what? Whose money is that, Sean?
Yeah, that's yeah,
It's the
exactly.
providers.
That's the providers.
Yeah.
That's 100% right.
Whose money? I mean, that's why the vendors don't care, because if they take that money away, they're like, oh, well, that's not our problem. That's not our money. And you know, a lot of those vendor contracts have provisions where the vendors get paid, you know, off the top, whatever you get paid, which and they don't always have back end provisions to shore up things like, you know, later denials and audits and things like that.
Well, that's right. And I have the T-shirt on that where the client wanted where the billing vendor was the one selecting the codes and didn't do a really great job of it. And so the client had to pay back a bunch of money to the payer and wanted to turn around and try to get that money back out of the billing company. And the real answer, and what it was very frustrating to say, is you might be able to get back what you paid the billing company for those claims, the 5 or 6% billing fee.
That's right.
That you paid. You're not going to get the full amount of that back, even though you trusted them to do this job.
That's exactly right. And, you know, and vendors are, you know, they're no fools, most of them. So they're prepared for those allegations and those lawsuits, and they have other law firms they use that they're not going to give that money up easily, especially if it's a vendor you're no longer using and things like that. So, yeah, and you're right. It's not always worth it to sue somebody for just that 6%. But dang, if you're not out hundreds of thousands of dollars. So,
right.
That's a great
Well,
point.
in the words of Ed McMahon, as he was talking to the great Karnak, we have in our hands the last slide. Go to the next slide. Thank you. So these are some strategies.
If the paper records didn't date you, Sean, that did.
Oh, yeah, I know. Yes, that's exactly right. For those of you who know who Johnny Carson and Ed McMahon were, if not, send me an email and I'll explain it to you later.
There you go. Find on YouTube.
Here is some stuff that we were talking about earlier on in the day. I am willing to do anything that a client asks us to do. And you know, sometimes you get some benefit from going outside, getting the congressional assistance, or getting some social media assistance. In the really old days, when every once in a while the local hospital here in Raleigh would go out of network with one of the big payers, and then there would be full page ads in the newspaper, which it just boggles the mind now, where the hospitals were trying to convince employers to stop using, I think it was United, because United didn't have the hospital in network. You know, those are some interesting and sometimes effective lateral approaches. The real answer, to my mind, and Ross, your experience may be a little different though, is to really focus on the substance of what the audit has sent in. It is fairly rare for a government payer to be persuaded even by congressional intervention, because a lot of times they will say, look, these are terrible records. What do you want me to do about it? Are you ready to go tell your constituents that you are okay with wasting taxpayer money? I mean, those are challenging conversations. That being said, Ross, I think you've had more success with those approaches than
we have done it. And we have, you know, I would say it's good sometimes to get attention to a matter where you are truly being unfairly treated. I wouldn't usually try to go through my congressman. I would probably go directly to CMS if I could, and use good contacts there. Although, you know, so maybe your congressman is the right person, sits on the right committee, and they can get CMS's attention when no one else can. And look, that is something I made a big speech about the Department of Insurance earlier, and I stand by that. But on the federal payers especially, occasionally going to CMS or your congressman, then to CMS, can get the right person's ear. I don't see it so much successful on ordinary payment disputes. It's more successful when you've been revoked or terminated, or you're under just an extremely onerous payment suspension or something like that. It's more helpful in kind of extreme situations, but it can be. That's absolutely right.
And isn't that more useful in a situation, and this is really focused on government payers again, but where the Medicare administrative contractor is taking a really aggressive view and there could actually be some dispute about it? I mean,
That's exactly right. Yeah,
ordinary.
that's right. Where you're coming back and you're saying, hey, look, they're saying that, their LCD says X, that contravenes the national coverage determination, or it contravenes some other regulatory guidance. We just think they're plain wrong. And here's why. And people have had success in recent years, especially on, arguing that LCDs that did not go through the required notice and comment period and things like that were invalid. So there is ways to do this, but not always. It's just not the right move for everyone, I would say. Another one thing I have seen a lot of success on, and I will preach this all the time, is sometimes that compliance officer's letter or the letter from the right person in the company can actually get a little bit more attention than the lawyers do. The problem with the lawyers is this. A lot of times we ghostwrite these, but we don't send them on our letterhead, because if I put it on my letterhead, it goes to the general counsel's office. The general counsel's office tosses around and goes, what's going on with this? And then they call their law firm. And then it's like a whole thing, and it can sometimes take a while. Sometimes what we do instead is we ghostwrite letters for the compliance officer or somebody else to respond to the audit, respond to the appeal, or just bring a compliance complaint to the plan or whoever, saying, hey, here's the things we think you guys are doing wrong on these audits, or here's the thing that we think you missed.
And this is the payer compliance officer, right? That you're talking about reaching out.
No, we would use ours. We would talk to their compliance officer if we know who it is. Does that make sense?
Right.
Yeah. So we would either use our compliance officer if we were a practice that was big enough to have its own compliance officer, or we'd use somebody from the practice trying to get to their compliance officer.
Gotcha.
That makes sense. If we think, especially, that what they're doing is illegal or somehow contravenes regulatory requirements. So, and there's various other things. I wouldn't highly recommend. You can do the CMS online complaints for Medicare Advantage. You can try to go to the Department of Labor. Different things. Some people try from time to time, and it can get their attention. Although I think with those two, third and fourth bullets, I'd warn you that it may have the same results as going to the Department of Insurance, which is making them madder than you want to. Social media assistance. This is a good tool. However, I would recommend with this that we do this with the advice of a good PR group or your law firm, because you do want to be careful you're not out there, making misstatements or things like that about the group. You also want to be careful that you're not drawing too much attention to it. Sometimes you may be drawing more attention to the issue than you really want. Patients might get scared to come to your practice, things like that, if they think they're not going to be covered. There are some very good PR groups that actually specialize in payer disputes, and we often engage them through the law firm, so that our discussions on strategy and things like that can be privileged, who can really help with those. If you're a big group having a big public fight with Blue Cross, and Blue Cross is slamming you in the paper saying you no longer want to, if you're in a small town and the whole town's industry is based on one or two companies and they're all Blue Cross companies, and suddenly you're out of the network Blue Cross, and you're really worried, and they're slandering, you feel like they're slandering you or your practice. It can be very helpful to engage with these groups and figure out how you want to message to the patient. So there can be a lot of value in it.
We reached the end of our time.
Oh, okay. Don't forget the patient.
Don't forget the patient. Well, we want to thank the AMA for giving us this opportunity, and we want to thank you for paying attention. And please let us know if there is anything any questions we can answer.
Thanks, Shaw.
That does conclude today's presentation, and thank you to our speakers for sharing their time with us today. Once again, we encourage you to check out the AMA's website for the practical tools and resources available there to support private practices. Have a great day.